share my thoughts on frailty in the older surgical patient. So these are my disclosures. As we've known for quite a while, age is associated with an increase in operative morbidity and mortality. And if we look at patients at the extreme of age, say the 80-year-olds, if you look at these major operations such as esophagectomy or pancreatectomy, we see these very substantial operative risks. In addition, we know that functional recovery can be very challenging in this population. On the left side, you'll see a graph of functional recoveries, or IADLs and ADLs, after abdominal surgery in patients 60 and older, so kind of the younger old. And what we see is this big dip in function right after surgery and very sort of long and protracted way to recovery. And in addition, on the right-hand panel, you'll see the early data out of Canada showing that if you do engage patients in trimodal, multimodal rehabilitation, looking at sort of light exercise, protein supplementation, and anxiety reduction, you can actually increase functional reserve as patient cohort on the top line there, so that when they have this sort of physiologic assault of surgery, they don't go dip into that vulnerable zone and actually have an accelerated recovery in terms of their function. So what is frailty? As surgeons, we often think, well, we know it when we see it, but there really are sort of specific definitions of frailty. There's sort of the functional model. It's defined by specific functional deficits in function, nutritive deficits, cognition, sort of sensory dysfunction. And then there's sort of the accumulation of deficit model, which is you sort of stack up and add up the disease diagnoses and the deficits to give you sort of more of a numerical score. But what a lot of people are sort of weighing in on is sort of the biologic syndrome of frailty, which is sort of this defined as being sort of a decreased reserve and resistance to stressors. And that's sort of characterized by weight loss, exhaustion, and poor strength and slowness. And frailty appears to be a much better predictor of operative morbidity and mortality than just age alone. And this has been demonstrated in multiple studies. This is an elegant study done by the VA group where they took using the RAI frailty measure and then also looking at the sort of magnitude of the operation. So they looked at 30, 60, 90-day mortality, 30, 80, 180 day mortality. And then on the y-axis looked at mortality, and on the x-axis looked at increasing physiologic stress of the surgery. And the black line there is the frailer patients. And what you see is this sort of increase risk exponentially as the operation gets more challenging for the patient. And this is very different from the less frail patients. So just another reminder that frailty puts our patients at risk, especially with these high-risk procedures. So with an eye on trying to improve outcomes in older adults, the American College of Surgeons and the American Geriatric Society got together and said, we need to make some guidelines to try to optimize outcomes in these patients. And so the first set of guidelines were around the preoperative evaluation and optimization, and the second were around sort of perioperative care. So I'm going to focus primarily on what the content is in trying to prepare your patient optimally, that first set of guidelines. So really, the main components are, goals of care alignment, right person, right operation, identification and mitigation of these frailty traits that make patients vulnerable, and then trying to design sort of a safe transition to home after surgery. And so really, when a lot of people think about rehabilitation, they think about boot camp, diet, and exercise. But for older patients, it's very different. There are very many domains that need to be addressed. There's cognition, there's function, there's polypharmacy, comorbidity, depression, anxiety, social isolation. So a lot of these sort of wraparound programs need to address all of these areas of vulnerability. So really the gold standard for that approach was piloted by Duke and then rolled out more broadly in their healthcare system. And this is really a high-touch program where patients actually go to a multidisciplinary clinic. They have all these assessments done and optimization programs. This is paired with an inpatient team to try to improve outcomes. And their results are very remarkable. If you look at the left-hand screen, looking at these metrics that your health system cares about, like with stay readmission, they really move the needle. And then on the right panel, you see sort of discharge disposition, patients going home, being independent, more of a patient-centered outcome. That's very important to patients, and they've actually seen a lot of improvement there as well. So very successful program. So what are these key components? Like I said, right person, right operation, making sure that the goals of care are aligned, that you can actually accomplish what you need to do for the operation for that specific patient, making sure that there's advanced care planning, advanced directives, surrogates identified. And this is a little trickier in older patients because, we have to back it up and say, okay, before I even have this conversation, can this patient, do they have the cognitive ability to engage in making sure that If they don't, they have their surrogate there. And even if they can, to make sure that the surrogate's there to actually witness this conversation, because those goals aren't always completely aligned. And just being very realistic about eliciting the health goals of the patient. Do they want to prolong life? Do they want to preserve function? Do they want to stay independent? Are they dealing with symptoms? What do they want to get out of the operation? And then really having a frank conversation about what they want and what you can provide. Sort of the balance between those wishes and sort of the morbidity, mortality of surgery, the potential functional decline and loss of independence associated with a major operation. So there's certain things we can, think about, preserving all of these different domains of frailty. We don't really have sort of a brain optimization pill. So we really have to work on preservation of cognition. And there are sort of evidence-based ways to take care of patients, older patients before surgery, to preserve cognition, sleep-wake preservation, reviewing medications. They often polypharmacy that might be delirogenic, making sure patients have adequate hydration, simple things like removing the earwax so they can actually hear what you're saying, have the glasses, and even have sort of a sign-up program for family members, COVID willing, that they can actually be at the bedside and participate in reorientation. That can make a big difference in terms of brain function. In terms of exercise, you really need to tailor these exercises to what patients can do and where they're most vulnerable and the skills they need for surgery. So just simply starting by asking how much people can walk and then encouraging them to do it and make sure they have a safe place to do it, hopefully someone to do it with, and then just increasing their duration by 5 minutes every couple of days. And then specific exercises that are focused on A, where older patients lose muscle mass and ability, and B, where the muscles you need to recover from surgery. So a classic would be encouraging your patient to do a sit to stand. This is so critically important for getting up and for maintaining mobility. And these muscles are the ones that atrophy pretty quickly. Simple core exercises, just like sitting in proper posture for a few minutes, can actually make a big difference. And then anything, the light weights with anything for upper body strength, so patients can help with transfer, lifting things over their heads. So really, it doesn't have to be super boot camp, but really focus on these muscles people need to recover from surgery. In terms of nutrition, really, so the basic principles apply here, except making sure that you screen for some aspiration risk, which can really impact the optimization of someone's nutrition. Obviously, patients have more likely to have comorbid conditions like diabetes and renal diet, but also make sure that your patient doesn't have food insecurity, because this is very much a underdetected problem in the surgical patient and has been associated with poor outcomes after surgery. And then finally, just thinking about what that soft landing is going to be after surgery. So this seamless transition to home. We know patients really want to go home. So anything you can do to make sure if there's any assist devices, getting them in advance and making sure people are sort of in-serviced on them so they can seamlessly use them at home. Simple things like pulling up throw rugs so you don't have a trip risk, making meals in advance, putting them in the freezer, and making sure people sort of call in all their favors with friends and family so that they have people to take care of them at home. And then, often people this isn't on top of mind when they're kind of nervous about surgery, just making sure you double down on these things and make sure people are marshaling all of their resources. So, if these pretty low-tech interventions are going to make patients do better after surgery, why doesn't everyone do them now? Well, this is a survey in 2016 of surgical oncologists asking basically that question. The first question was, do you do any kind of frailty screening? What kind of geriatric screening do you do? And about 6% actually do a comprehensive geriatric assessment. But over 70% said, yeah, I would be willing to delay surgery if I could optimize these patients. But they're not doing it because they think it might be cumbersome. I'm not sure how you would actually do it in the clinic. It might be clunky, might delay things. And also there's sort of lack of expertise. Like, I don't really know. I want to do it, but I don't really know what to do. So I'll just finish out saying how we're trying to address this gap. So our research team is working through the Cancer Alliance to test a frailty screening and optimization program that can be really rolled out to any kind of hospital. It's a multi-center randomized trial, and really the main goal is A, can you do frailty assessment, and B, can you mitigate risk, and C, are patients going to recover better if you do implement it? So I'm often asked, what's the best frailty screen to use in a surgical clinic? What about this one? What about that one? Everyone's got an eponymous name. Well, I think the short answer is, whichever one you're able to roll out in your clinic and get buy-in from your staff to roll it out. I'm sort of a little bit biased against anything that requires a lab test that will need to be drawn and checked later and probably won't get done, or requires any special equipment that has a way of sort of walking off on its own. So I've sort of landed on the Edmonton Frail scale. And the nice thing about it also now has a digital version that you can use for remote visits. But the thing that I like about it is it can be performed by someone without any medical training. It's fairly quick. Doesn't require any special equipment. It gives you a score that actually has been validated to predict surgical risk. But what I really like about it is there's a couple questions, 1 or 2 at each domain. So you can actually like flag which little frailty thing trait is actually pulling down their score. And then you can say, oh, I'm going to target that area, as opposed to having some composite measure with no information behind it besides some labs and other measures. And so what we've done in this study is basically hung the whole intervention off the Edmonton Frail Scale and said, okay, we're going to send you this toolkit where, depending, this intervention's been rolled out to academic centers, major health systems, and private practices. Can you implement this and do this optimization? So you don't have to have access to all kinds of services. We give you little bundles, little printed things, little videos, versus, if you're in somewhere that has lots of resources, major cancer center, and you have nutrition and OT and PT, there you go. So basically screen patient for elective operation, pull out the Edmonton Frail traits, and then try to optimize them. So the way we've designed it is a randomized trial. We have a control arm, and then we have 2 intervention arms. One is just to get the toolkit with some instructions, and the other is actually having an implementation coach to help you figure out barriers to implementation and trying to get it implemented. So stay tuned. What we're looking at is whether, if you use this toolkit, are your patients in aggregate going to return to baseline function faster? So hopefully we'll have some solutions soon. So in summary, frailty is associated with poor surgical outcomes in older patients. And then really successful optimization in this population is not just sort of boot camp, diet and exercise. And it's really around identifying all those frailty traits, things that put patients at high risk. In addition to malnutrition and low muscle mass, there are issues around social support, cognition, depression, anxiety, polypharmacy, all of these areas that need to be assessed, and a targeted implementation of a scheme to try to optimize these. Thank you so much for allowing me to speak to you, albeit remote, and enjoy your meeting.